So good morning again. We are going today to discuss about the nerves of the head and neck, the basic information, and something about the lymphatic drainage in the region of the head and neck. About the nerves, generally the nervous system is divided to the two main groups. This is a topic of the second semester, of course, but to have an idea about the nervous system, we classified them to the central nervous system, or CNS, and peripheral nervous system, or PNS. The central nervous system is composed of two parts, the brain, or cerebrum, and spinal cord, or medulla spinalis. This is the two main components of the central nervous system. Then, whatever is outside of this central nervous system, it's considered as a peripheral nervous system. And this peripheral nervous system, we divide them to the cranial nerves that already you are familiar with which cranial nerve it passes through which opening of the skull. And also we have another nerves that they are called spinal nerves that the details we are going to discuss in second semester. So, and I would add another subclassification of the PNS or peripheral nervous system as an autonomic nervous system as a third one, which is composed of parasympathetic and sympathetic. So generally, the central nervous system is divided to the brain and spinal cord, peripheral nervous system as a cranial nerve, spinal nerve, and autonomic nervous system, which is the sympathetic and parasympathetic. This is the number and the name of the cranial nerves that definitely you have to know without any interval to think about. This is automatically you have to know the name and the number of the cranial nerves. And as you know, we have 12 paired cranial nerve. You see here the cranial nerve number 0 that we are going to discuss is a little bit complicated nerve that they found this nerve as a terminal nerve or nervus terminalis. It has a very close relation with the olfactorius, but it doesn't belong to the olfactory nerve. It's somehow in some animals, for example, they are playing role for the some sexual behavior and reaction of this animal to the pheromones. We don't know so much about this nerve, but we know that it exists, so that's why sometimes it's called cranial nerve number 0, or sometimes it's called terminal nerves and other terminology for this one that we are going to discuss it next semester. But in anatomical nomenclature, so we are using this 12 number that the first cranial nerve is olfactory nerve, which is responsible for the smell, the optic nerve, which is responsible for vision, oculomotor nerve is cranial nerve number 3, which is responsible for innervation of the most of the muscles of the eye, the skeletal muscle of the eye, and also some smooth muscle of the eye. Then trochlear nerve is the pure motoric nerve, which is responsible for innervation of only one muscle, which is the superior oblique muscle. Trigeminal nerve is cranial nerve number 5, which is divided to the 3 branches that definitely you have to know, that the first branch, second branch, and third branch of the trigeminal nerve as a V1, V2, V3. The first one is ophthalmic nerve, the second one is maxillary, and the third one is mandibular nerve, yes. So those are the three branches. We are going to discuss about this nerve a little bit more details, because this nerve is innervating the most of the area of the head, the sensitive innervation, and partially the motor innervation through the mandibular nerve, the masticatory muscle, for example. Then we have the abducens nerve, is the cranial nerve number 6, which is a pure motor, is innervating one muscle, is the lateral rectus. Very important nerve in the head and neck region, and is fascial nerve, is a mixed nerve that it contains motor and sensory fiber. And as you know, and we said it in the lecture, this fascial nerve, for example, is innervating which groups of the muscle? Mimic muscle, thank you, or fascial muscles of the facial expression. Then we have cranial nerve number 8, which is called vestibulocochlear nerve. Is composed of, as a matter of fact, two nerves, the vestibular nerve for, you know, what? Balance and equilibrium, thank you, and the cochlear nerve, which is responsible for hearing or auditory system. So cranial nerve number 8. Then glossopharyngeal also is a complex nerve, is a mixed nerve composed of sensory and motoric fiber. And we are going to discuss the nervus vagus or vagus nerve is the longest cranial nerve that you have. Is not only, this is the only cranial nerve that is not stay in the region of the head and neck region, but it goes farther. It goes through the thorax, and then also it goes through the abdominal cavity, is innervating the most of the GI tract, the gastrointestinal organs, and is finishing at the level of the left colic flexure, so it's very important. We are going to discuss. And finally, the cranial nerve number 11 is accessory nerve, which has a very mysterious pathway, or interesting pathway, it's better to say. We are going to discuss. We have two parts of that. It's the spinal part and the cranial part. And finally, the hypoglossal nerve, which is the cranial nerve number 12, and is responsible mainly for the innervation of the muscles of the tongue, thank you, with some exception that we already discussed about this. So this is the name and number of the cranial nerve that definitely you have to know. And this is just a picture to realize that the area of the innervation of those cranial nerves, this has come from the Gray's Anatomy, this picture. And as you see, those are the exit of all this cranial nerve from the brain, which is a chapter that you have to know it in the second, or we will discuss it detail in the second semester. What you see from this picture, you see that there are some red fiber, or the fiber that is showing as a red color, and the fiber that they are showing as a blue color. The red one is called efferent fiber. Efferent with E starting is the motoric fiber. Yes, it means that they are coming from the nervous system and is going to the usually muscles, or can be other things like a glands. The blue one is the afferent fiber, which are sensory fiber. And sensory fiber, in a while I will tell you that we are dividing as a general sensory, a special sensory, and so on. But they are the things that they have in the peripheral part, they have receptors, and they are stimulating, and they are carrying the information from the peripheral to the central nervous system. That's why they call it afferent fiber. So, and if you look at it generally to this picture, those are the area of the territory of each cranial nerve that it's supplying. For example, here is the trigeminal nerve, And as you see, the trigeminal nerve, it has mostly the afferent fiber or sensory fiber. It means that the feeling of the pain, the feeling of the touch, the feeling of the temperature, heat or cold, pressure, those are the general somatic sensory fiber. It has just through the mandibular branch of the trigeminal nerve also the motoric fiber that is innervating, we said, masticatory muscle plus some extra muscle that we are going to discuss. So as you see, this cranial nerve, that's why they call it the cranial nerve, is the region of the head, it is located there. So you see that head and neck, head mostly is the head and neck. The only one that you can see is the vagus nerve, that it contains the mixed fiber and not only supplying, for example, the muscles of the larynx that last time we discussed, and with the accompanied with the glossopharyngeal, they make the pharyngeal plexus to innervate the pharyngeal muscle, and the other things is extended to the thoracic cavity, for example, for innervation of the heart. Sorry. Then it goes to the abdominal cavity, and as you see, is innervating most of the part of stomach, intestine, the small intestine, large intestine, and the territory of the vagus is finishing here as a left colic flexure, yes? So that's why the vagus nerve, which is the longest nerve, cranial nerve, is not remaining in the head and neck region, but it's going farther to the thorax and abdomen, that is innervating, and then we are going to discuss the details, how is the effect of this innervation of the vagus, which is the most important or largest parasympathetic nerve of the body, and the other fibers. So this is giving you the general idea why we say it cranial nerve. And this picture in this side is the central nervous system, just showing you, and it's of course very important, just showing you this cranial nerve from which part of the brain is coming out, respectively, mainly from the brain stem here. That is a chapter of the second semester on central nervous system, but what you have to know especially for your test, that definitely you will have such a type of this question, that this 12 cranial nerve, it passed through which foramens of the skull. So one by one, we discussed it in the neurocranial bone and the splachocranial or viscerocranial bone. But here we are going to revise once more because it's extremely important and you have to, it's a must, and you have to know it, yes. So this is the first, and always this number is going from anterior to the posterior, yes. So the first one is here and the last one is here, yes. So 1 and 12. So the first cranial nerve, which is olfactory nerve, is passing through the cribriform plate, those openings of the ethmoidal bone, which is the horizontal plate, which is the cribriform plate of the ethmoidal bone. Then the second cranial nerve, which is optic nerve, is passing through the optic canal, together with very important arteries, ophthalmic artery. Then here you have the superior orbital fissure, and through the superior orbital fissure, it passed the cranial nerve number 3, here, oculomotor nerve. Here you have the cranial nerve number 4, is the trochlear nerve, it's going to the superior orbital fissure. Here you have the trigeminal nerve, and as you see the trigeminal nerve, it has first branch, second branch, and third branch. Only the first branch of the trigeminal nerve, which is called ophthalmic nerve, it passing through the superior orbital fissure, and immediately it gives 3 main branches, which are called lacrimal, frontal, and nasociliary nerve. That is passing also through the superior orbital fissure. And the last nerve that is passing through the superior orbital fissure is this nerve, which is called abducent nerve, and it's the cranial nerve number 6. So 3, 4, 6, and V1 is passing through the supraorbital fissure. Then you have the second branch of the trigeminal nerve, which is going through the foramen rotundum, thank you, or round foramen, and is open to the space which is called the pterygopalatine fossa. So foramen rotundum is open to the pterygopalatine fossa. In this case, one of the content of the pterygopalatine fossa, which is a content of your test, yes, in next week, and infratemporal fossa, so they are the content. So maxillary nerve is one of the content of the pterygopalatine fossa, and maxillary nerve here. Then it's the mandibular nerve. The mandibular nerve is going to the infratemporal fossa through this opening, which is called foramen ovale or oval foramen. So the content of the infratemporal fossa is mandibular nerve. The content of the pterygopalatine fossa, it's maxillary nerve, about the cranial nerves. After that, we have here the opening, which is called the porus acousticus internus, or internal acoustic meatus. And as you know, two nerves that are going inside, the fascial nerve and the vestibulocochlear nerve. The fascial nerve, it has its own area, which is in the superior and anterior quadrant of this meatus it passes, and it's going through the fascial canal, through this bone, the petrosal part of the temporal bone, and it's coming out of the skull through fascial nerve is, yes? No, this is the mistake of the student that usually they say, and it's extremely, is wrong, because otherwise you have to see from the external ear some nerve that is coming out. It's not at all. And this is stylomastoid foramen. Stylomastoid foramen, between the mastoid process and the styloid process, the fascial nerve is exit or emerging out from the skull. So these two cranial nerve. Then we have cranial nerve number 9, glossopharyngeal nerve, and 10, and accessory nerve, cranial nerve number 11. All of them, they are passing through the jugular foramen, especially the ventromedial part of this foramen. They are the place for these nerves. And what I said in the beginning, that the accessory nerve, it has the interesting pathway. Sorry. That accessory nerve, it has two roots, or two parts. One part, which is here and is coming out inside the cranial cavity from the neck region, from the spinal cord segments, is called a spinal root, or a spinal part of the accessory nerve. That is passing through the foramen magnum, and then it's going and is joining to the cranial part of the accessory nerve, and they make the accessory nerve, and accessory nerve is passing through the jugular foramen. And finally, the last nerve, which is the cranial nerve number 12, is the hypoglossal nerve, that is passing through the hypoglossal canal. Yes, those are this information is extremely crucial and important for you to know it for now, and then in second semester, you add some information about each fiber that it's important. So to have an idea, each cranial nerve, what it does, and is the area of the innervation, we go shortly through this one by one nerve to have some idea when you are studying those cranial nerve. It must not be just a name for you. The first cranial nerve, olfactory nerve, is originated from the receptors in the olfactory area of the nasal cavity below the cribriform plate of the ethmoidal bone. There are some cilia that at the end they have the receptors, and they are sensitive to the chemicals, molecules that they are breathing by the nose, and they are in the air, and they are stimulating this fiber, and the axons of these bipolar cells or olfactory cells, they are passing through this cribriform plate, and they go to the brain. In the frontal lobe, you have a bulb of the olfactory that it has its own pathway. So this nerve is pure sensory, special sensory fiber it has, and this special sensory fiber is responsible for perception of the smell. Second cranial nerve, optic nerve, which is passing through the optic canal, and you can see it's covered also by the meninges, as you see. It means that the first cranial nerve and second cranial nerves, they are not a true cranial nerve. They are the part of the central nervous system, the details we are saying. And this is important. The optic nerve, because it's a part of the central nervous system, is covered by the meninges. And those are the layer of the meninges that you see that is covering the optic nerve. This is also a special sensory. It contains the special sensory fiber and is responsible for the vision. So, for vision, optic nerve. Oculomotor nerve, as we said, is passing through the superorbital fissure, and it's a mixed nerve. So it means that it has a motoric fiber, but the motoric fiber is subdivided to the visceromotoric fiber and the somatomotoric fiber. The somatomotoric fiber is innervating voluntary muscle or skeletal muscle. So oculomotor nerve is innervating all muscles of the eye, the extraocular, the voluntary part, except this muscle, which is called superior oblique, which is innervated by cranial nerve number 4, and this muscle, which is called the lateral rectus muscle, which is innervated by the cranial nerve number 6. So the rest of the muscle that you can see it, and in the next slide I will show you, is innervated by oculomotor nerve. But oculomotor nerve also, it has a parasympathetic or visceromotoric pathway for innervation of some smooth muscle. For example, the muscles that they are narrowing the diameter of your pupil. So it's called the sphincter muscle of the pupil, is innervated by oculomotor, by visceromotoric fiber, and also the ciliary muscle responsible for accommodation of the lens of your eyes when you are reading some text in the near vision. So we are going to discuss it. It's extremely important. So here you can see the oculomotor nerve that is coming from the superorbital fissure. Very nice picture. And after that is innervating the levator palpebrae superioris, the rectus superior, rectus medialis, and rectus inferior, and obliquus inferior. So you see that this nerve is not innervating the lateral rectus here and the superior oblique that is here. So we don't have, we have a special innervation for these two. That is the inferior, the superior oblique is by the trochlear nerve, and lateral rectus by abducens nerve. Cranial nerve number 4, which is passing also through the superorbital fissure and is responsible for innervation of this muscle only. So it means that it's a pure motoric, somatomotoric fiber it has, and is innervated by this, and is innervating this muscle, which is called superior oblique muscle. The trigeminal nerve is quite a little bit complicated, because this trigeminal nerve, our trigeminal ganglion, which is here, is located in the impression for the trigeminal ganglion near to the apex of the petrosal bone of the temporal bone in the anterior surface. It's giving the 3 branches. We said the ophthalmic, the maxillary, and the mandibular nerve. The ophthalmic, we said that it passed through the superorbital fissure. Maxillary passed through the foramen rotundum, and mandibular nerve to the foramen ovale. And those area in the head, those are the territory of the innervation of the ophthalmic nerve, the green one. The territory of the maxillary nerve is this area, mainly the upper jaw, and some part of the temporal region is for the maxillary nerve, and this larger area of the lower jaw and most of the part of the temporal region is innervated by the branches of the mandibular nerve. So as you see, it's taking part for the innervation of the trigeminal nerve is taking part for the innervation of the most of the part of the head region. And as you see, if we divide those regions, this is the area that is supplied by the ophthalmic nerve. This is the area, this dot nerve lines that you can see. It's the area of the maxillary nerve, and those area is innervating a sensitive innervation of the mandibular nerve. This is we are going to discuss, and if you want to just remember, there is a line that is connecting the two external acoustic meatus or two auricle of your ear that you have. This is called interauricular line. Yes, this is the line that from one auricle approximately is going to the other side from the other auricle. Yes, this line. What is in front of this line, the connection of two auricle? It's the area and territory of the trigeminal nerve. So you have to know from this interauricular line, which is connecting the auricle with the other auricle. So what is in front? It's the area for the sensitive innervation of the skin in territory of the trigeminal nerve, which is the three branches that you have to divide it. And then we are going to discuss. This is very important. So you see that the trigeminal itself is a huge area of the head, is responsible for the sensitive innervation of this huge area of the head region. This backside from this interauricular line, the backside, this part is innervated by the spinal nerve. There are the cervical nerves. There are the posterior branch of the cervical spinal nerve is innervating this area, and this part that you can see, it's the area which is innervated by the ventral branch of the spinal nerve from the cervical region as a cervical plexus that we are going the details to discuss. So this is very nice picture to have an idea where are the territory of the each innervation of the cutaneous innervation or sensitive innervation of each cranial nerve, and the spinal nerve posterior branch and the spinal nerve the anterior branch. Abducens is the abducent nerve. It's passing through the supraorbital fissure and is going, and as we said, is a pure somatomotoric fiber, is responsible only for innervation of one muscle, which is called the lateral rectus muscle. This lateral rectus muscle is moving your eyeball to the lateral side, which is abduction of the eye. So if you are looking outside, so this is the function of the lateral rectus muscle, and this is the abducens muscle. So in ophthalmology, ophthalmologist is making examination and asking you to do the abduction of your eyeball, and if there is a damage of the abducens nerve, so the paralysis of this muscle can happen. As we said, we are closing to the more complicated nerve as a fascial nerve. This fascial nerve is containing the sensory fiber and motoric fiber. And as we said, this fascial nerve is going to the area of the fascial nerve in the porus acousticus internus or internal acoustic meatus in the superior and anterior quadrant, and enter to the fascial canal inside this petrosal bone, and it's going directly anterolaterally, then it's going posterolaterally, and then it's going down as a descending part, and somewhere here between the mastoid process and the styloid process, somewhere here behind of this lobe of the ear or the auricle, So it's coming out through the stylomastoid foramen. After it's coming from the stylomastoid foramen, it gives 3 branches. This is the posterior occipital branches that we are going to discuss. Is supplying the motoric fiber for the posterior auricular muscle and the posterior belly of the fronto-occipital muscle that we mentioned. It is the epicranius muscle, and is giving the branch to 2 muscle more. The posterior belly of digastric muscle is the suprahyoid muscle, is a chapter that you have it in the test, and also the stylohyoid muscle, which is one of the another suprahyoid muscle. So this is the fascial nerve. Then the interesting course of the fascial nerve that is entering to this largest salivary gland, which is called parotid gland. The fascial nerve, extremely important, is entering to the parotid gland and divide the parotid gland to the superficial and deep part of the gland. Yes, so the border between the superficial and deep part of the parotid gland is fascial nerve. Inside the parotid gland is making a plexus, and it gives 5 branches, which are going to the temporal region as a temporal branch of fascial nerve, is going to the zygomatic region as a zygomatic branch of the fascial nerve, is going to the buccal region, the yellow one is as a buccal branch of the fascial nerve, and is going to the lower margin of the mandible as a inferior marginal nerve or branch of fascial nerve, and one or a few fiber is going to the neck region here, and that's why they call it cervical branch of the fascial nerve. So temporal, zygomatic, buccal, marginal mandibular, and the cervical branch of the fascial nerve from intraparotid or parotid plexus. All these nerves, they are motoric fiber, and all these nerves, they are responsible for innervation of mimic muscle or the muscles of the facial expression. Yes? So this is extremely important to know. Just if you want to remember the name of the branches of the cranial nerve, is enough to put your hand in the parotid region, and according to the direction of your finger, you can remember the name of the branches of the fascial nerve: the temporal, zygomatic, buccal, marginal mandibular, and cervical. This cervical branch of the fascial nerve is innervating the platysma. So we said it, platysma is the superficial muscle in the skin region of the neck region. It's extended to the face also, and this is the fascial. The cranial nerve number 8 that we said that it's passing through the internal acoustic meatus, they are divided as a 2 nerve. The vestibular nerve that is going to the inner ear, and they have connection with the receptors in the semicircular canal and utricle and suckles for orientation of your head. And this is responsible for the balance and equilibrium. And we have a cochlear nerve, which is responsible for the hearing, and they have, both of them, they have a special pathway that in the nervous system we are going to discuss. Glossopharyngeal, the cranial nerve number 9, is the nerve which is a mixed nerve. It has a lot of fiber, and sensitive fiber and motoric fiber, and is innervating, for example, one of the branches innervating the middle ear as a tympanic branch, and it's connected with one of the parasympathetic ganglion as an otic ganglion, and is responsible for the secretion of the parotid gland. So innervating the parotid gland, is innervating the palatine tonsil, is innervating the posterior 1/3 of the tongue, in the root of the tongue here, is innervating the, if you remember, the pure innervation of this muscle of the pharynx. Pharynx is the stylopharyngeal muscle, so is innervated by the glossopharyngeal, the pharyngeal branch of glossopharyngeal. Then is playing role for the innervation of the muscle of the pharynx together with the vagus nerve, that they are making the pharyngeal plexus as well as sensitive innervation. And if you remember here, we had the at the bifurcation of the common carotid artery to the internal and external carotid artery. Here, at the level of the bifurcation, you have a paraganglion, which is the glumus caroticus, or carotid body. It's the chemoreceptor and is responsible for the changing of the carbon dioxide and oxygen in the blood. So it's innervated by glossopharyngeal. And the beginning of the internal carotid artery also, it's becoming widened, and it has another terminology as a carotid sinus. And this is a baroreceptor or pressoreceptor, and is responsible for the changing of the blood pressure. So these two, that here is showing the carotid sinus, and here also is existing the carotid body or glumus caroticus. They are innervated by glossopharyngeal, not only glossopharyngeal, but also with vagus nerve. Extremely important that we are going to discuss. And here is the vagus nerve, the longest cranial nerve, that again you see that is innervating the carotid sinus, the baroreceptor, and glumus caroticus, the chemoreceptor, is innervating some part of the auricula, the posteromedial aspect of the external ear, is innervating the some part of the tongue, behind the tongue in the epiglottic region, and vallecula of the epiglottis and glossoepiglottic fold is innervated by vagus nerve, is innervating some part of the soft palate, is innervating the muscles of the pharynx together with the glossopharyngeal nerve, and is innervating the muscles of the larynx, that last time we discussed it. And then it goes to the thoracic cavity, innervating the lung, innervating the heart, is going to the abdominal cavity for innervation of the liver, stomach, spleen, kidney, the small intestine, the large intestine, till left colic flexure. So the flexure that the transverse colon finishing and the descending colon starting, vagus is finishing here. Very important. The territory of the vagus is finishing at the left colic flexure, or they call it splenic flexure. So this is the vagus nerve that we'll talk about this a lot. And here is the accessory nerve with its interesting pathway, remember, not to be confused. Accessory nerve is the only cranial nerve that not only it has an origin in the brain inside, but also some nucleus and origin also is having from the spinal cord. As you see, here is the foramen magnum, and through the foramen magnum, the spinal cord or medulla spinalis, it enter to the foramen magnum and continue to the cranial cavity as medulla oblongata. Yes, so the foramen magnum, it will be a transition place between the medulla spinalis and medulla oblongata. And as you see here in the spinal cord, in the cervical segment, those are the fiber as a spinal root or a spinal part of the accessory nerve that is coming inside the cranial cavity, to the cranial cavity through the foramen magnum, is joining with the cranial part from this nucleus, is called ambiguous nucleus. It's joining together, and they make the accessory nerve, which is coming out of the skull through, what is this foramen? jugular foramen, excellent. And immediately after it's coming out of the jugular foramen, this fiber that is coming from the cranial part, or nucleus ambiguous, of accessory nerve is joining to the vagus nerve. This is the vagus nerve, which is also passing through the jugular foramen and is joining to the one of the branch of the vagus nerve, which is very, very important, is recurrent laryngeal nerve. Last time I said that is extremely important, and now you will know, and in second semester we are going to discuss it more, that the recurrent laryngeal nerve, which is a branch of the vagus nerve, is a little bit complicated. But to understand this recurrent laryngeal nerve that is a branch of vagus nerve and is innervating the most of the muscles of the larynx except one, if somebody tell me. Excellent. Cricothyroid muscle, which is innervated by superior laryngeal nerve. So this recurrent laryngeal nerve, this motoric innervation that is innervating most of the muscles of the larynx, as a matter of fact, is the origin is from the accessory nerve that is fusing to the vagus, and it's then vagus is innervating the muscles of the larynx. So just this is the schema to know, to understand that there is some relation between the cranial root of the accessory nerve to the vagus, especially only one branch, which is recurrent laryngeal nerve. So this is a little bit complicated, but it's interesting. This spinal part of the accessory nerve is responsible for innervation of two muscles in the neck. One is sternocleidomastoid muscle is innervated by accessory nerve. The other is trapezius muscle. Excellent. So these two muscles, the sternocleidomastoid, the origin, the nucleus origin is from the spinal root of the accessory nerve, which is from the foramen magnum to the cranial cavity, joining to the cranial root, and then is coming out of the jugular foramen. So this is this picture that how the spinal root is coming from the foramen magnum, is joining to the cranial part, and they make the accessory nerve, which is coming out to the jugular foramen. And the last cranial nerve is the hypoglossal nerve, which is cranial nerve number 12, is making an arch it's going to the hypoglossal canal. Of course, it's making an arch to the carotid triangle. This triangle is extremely important, the carotid triangle. And it's going there further to the submandibular triangle, which is bordered by the anterior belly and the posterior belly of the digastric muscle and the inferior margin of the body of the mandible. So this triangle. Then is innervated, is going toward the tongue, to the sublingual region, and is innervating the most of the muscles of the tongue except one, which is called palatoglossus. The palatoglossus, because we said that sometimes it's classified as a muscle of the tongue because it's palatoglossus, and sometimes it's classified as a muscle of the soft palate because it's palato. So it is innervated by mainly glossopharyngeal nerve. So the hypoglossal nerve also, it's taking part, and this is the information for your test. Also that it's giving from C2, C3 or C1, C2, there is a fiber which is making a superior root for this loop, which is called deep ansa cervicalis. This is the deep ansa cervicalis. And from the C2, C3 is coming from the cervical plexus, the inferior root, and these two roots, they are joining together and they make this loop, which is called deep ansa cervicalis or ansa cervicalis profunda, and it's responsible for innervation of most of the innervation of the infrahyoid muscle, not all of them, but most of them. For example, the omohyoid muscle here, and the sternothyroid muscle and sternohyoid muscle. So this is the deep ansa cervicalis, which is also important and is related to this hypoglossal nerve. This is the hypoglossal nerve, which is the arch shape, and from this hypoglossal nerve is coming the superior root of the deep ansa cervicalis, or sometimes they call it descending branch of or descending part of the hypoglossal nerve. So these are the cranial nerves. Very quick. So and basic general information. To have a recapitulation and to have some general summary of this cranial nerve that I mentioned. As we said, there are 12 pairs cranial nerve that exit the cranial nerve through the foramens and fissures that we discussed already done. We said that all the cranial nerves, they are originated from the brain, with the exception of accessory nerve. The part that is a spinal root is coming from the spinal cord. This is another point. Then all the cranial nerve innervating the structure of the head and neck, exception, in addition, you have the vagus nerve. We said that it's going through the thorax and abdomen to innervating the organs that we mentioned it. 4 cranial nerves, they are containing the parasympathetic fiber or visceromotoric fiber. The cranial nerve number 3, 7, 9, 10. Those are extremely important cranial nerves because those nerves, they are responsible for the parasympathetic innervation of some targets. It means that some smooth muscles and for innervation of some glands. So visceromotor or the parasympathetic fiber is innervating the smooth muscle, not voluntary muscle, involuntary muscle, and some secretion of the glands, which is also not voluntary. So that's why they call it autonomic nervous system. It's autonomic, so it's not under your voluntary control. Then the fiber that is going to this target, those are via the branches of the trigeminal nerve that in parasympathetic ganglion we are going to discuss more details. And vagus nerve, it's the cranial nerve that is carrying this parasympathetic fiber not only in the head and neck but also in the thoracic and abdominal viscera. So those are some important points of this cranial nerve that we said, and this is very interesting picture that it will be helpful for your next semester as well, that this 4 cranial nerve that we mentioned, the number 3, oculomotor nerve, 7, fascial nerve, the glossopharyngeal nerve, and the vagus nerve, these 4, they containing the parasympathetic fiber. The 3 is this parasympathetic fiber is related to the ciliary ganglion. This is a parasympathetic ganglion. And via branch of trigeminal nerve is innervating the target organ that we said it is smooth muscle, ciliary muscle, and sphincter muscle of the pupil. The fascial nerve, it has also from the genu of the fascial canal or fascial nerve is giving the parasympathetic fiber to the pterygopalatine ganglion, which is one of the content of the pterygopalatine fossa, for the responsible for the innervation of the glands, lacrimal gland, for secretion of the lacrimal gland, and also some glands in the nasal cavity, palate as well, and palatine tonsil. Then you have the glossopharyngeal nerve, which has a parasympathetic fiber, which is responsible for is connected with the otic ganglion and is responsible for the secretion of the parotid gland. Another branch of the fascial nerve, which is called chorda tympani, is going out of the skull through the petrotympanic fissure and is related to the submandibular ganglion for the secretion of the submandibular gland and sublingual gland. And vagus nerve, we said that is going down to the abdomen and thoracic. So those are the 4 nerves that they are containing parasympathetic, and we are going to discuss how they are connecting with this 4 parasympathetic ganglion, the ciliary ganglion, otic ganglion, submandibular ganglion, and pterygopalatine ganglion. And this is the structure that we already mentioned, that you have to know all this cranial nerve, where does it pass through this optic. This table, as I mentioned, is not that much easy, that we classified them to the sensory and motor, or afferent and efferent fiber. Each of them, they are subclassified or subdivided to the different part. As you see here, A is afferent. It means 3 kind of the fiber we have. This is just a basic introduction for the next semester to know it, and it's crucial important. That is not only afferent, but this afferent is subdivided to the 3 afferent. Some cranial nerve, it has general somatic afferent fiber, as an abbreviation of GSA. Why? What is it? The function for perception of touch, pain, temperature. Then you have general visceral afferent, is JVA. It's for the sensory information from the viscera. Viscera, it means organ. Yes? So you have a heart attack and you have a pain. Yes? This pain from the heart, from the viscera, from the organs is coming. Yes? So from the appendix, you have a pain. So this pain is coming from organ. So it's not somatomotoric. It's the general visceral somatoafferent or somatoafferent, but it's the visceral afferent. Yes? General visceral. Then we have a special afferent. A special afferent, they are responsible for smell, olfactory, taste, cranial nerve number 7, 9, 10, vision, optic nerve, hearing, cochlear nerve, balance, vestibular nerve. Yes? Those nerves, they are here. Those nerves, they have a special afferent, SA. And again, this efferent fiber, you have also 3E. It means motoric fiber. We have general somatomotoric or somatoefferent for the motor innervation of a skeletal muscle, the voluntary movement, yes. And for example, masticatory muscle, yes. And general visceral efferent, those are the autonomic nervous system responsible for smooth muscle, heart muscle, and glands, we said. And we have some specific, in some literature they write it, they are branchial efferent fiber. Those are the fiber that is responsible for the muscle, for innervation of the muscle, is the motor innervation of the skeletal muscle, that they are arising or deriving from the pharyngeal arch, mesoderm. So as a first pharyngeal and second pharyngeal arch, so there are those nerves, the trigeminal, facial, glossopharyngeal, accessory, and this accessory we mentioned about the muscles of the larynx that is going to the recurrent laryngeal nerve. So this is the introduction, that what is waiting for you, the details in the second semester to be prepared. Your hormone adrenal, it must be secreting and prepared for the second semester, because the real anatomy is nervous system is one of the most difficult part of the chapter of the anatomy, is starting this second semester, to know what is waiting for you, yes. But as we said it, for this coming exam that you need it, you need the name, you need the number, and you need that where is passing through this exam. And in some of the muscles that we said it, you have to know that the innervation of those muscles that is related to the head and neck region, like a suprahyoid, infrahyoid, mimic muscle, and masticatory muscle, yes? So be careful, pharynx, larynx, soft palate, hard palate, they are not included to this credit exam, yes, as we agreed. Temporomandibular joint is there. So this is the table for you that you can use it, the olfactory optic nerve. This is the special afferent fiber. Oculomotor nerve, we already mentioned it as a general somatoefferent and general visceroefferent. Trochlear nerve, only pure one efferent fibers, general somatomotor for the superior oblique muscle, abducens for the lateral rectus muscle, we mentioned. Trigeminal, we are going a little bit more details to these three branches of the ophthalmic, maxillary, and mandible, and those are the place that they are passing. This is the territory of the trigeminal nerve that I said that is interauricular line. This is one side and the other side. So what is in front? It's the territory of the trigeminal nerve. It's a small area that is innervated by the vagus and facial nerve in the ear region. So here is the dorsal branches of the cervical spinal nerve. Sorry, and this is the ventral branch of the cervical spinal nerve that they make the cervical plexus. Facial nerve, we mentioned it. This is a table for information. Glossopharyngeal, vestibulocochlear also. As you see it, glossopharyngeal nerve, almost it has all kind of fiber, yes? So GVA, GSA, SA, GVE, BE. And the most common is this vagus nerve that it compounds also all of this fiber. And you have to be able to explain is innervating which area that is innervating. And accessory nerve is a pure motoric fiber, is B, branchial efferent. The spinal root is innervating the sternocleidomastoid and trapezius muscle. And finally, hypoglossal is GSA, is a general somatomotoric nerve for innervation of muscles of the tongue, except the palatoglossus. So from this cranial nerve that we mentioned, so trigeminal, it's making a larger area and it is responsible for the larger area of the innervation of the sensitive innervation and some part of the motoric innervation. Facial nerve, mainly for the motoric branch of the mimic muscle and epicranius muscle. And the trigeminal nerve with these three branches that we mentioned, and we go to one by one quickly. This is the picture that we already mentioned, and some of the nerves that they are here, they are familiar with you. For example, the supraorbital nerve, which is a branch of the ophthalmic nerve. This is the territory of the innervation of the ophthalmic nerve for the sensitive innervation. And supraorbital and supratrochlear nerve. They are the two nerves that they are mainly responsible for innervation of the frontal region. Yes, and you know that the supraorbital nerve is arising from which foramen here? Supraorbital foramen or notch. So they are variable, either is notch or is foramen, so is variable. Then the area of the medial half of the upper eyelid by the infratrochlear nerve and the skin of the medial angle of the eye, this is the medial canthus they call it, and some part of the nose. The lacrimal nerve is innervating the lateral aspect of the eyelid and the skin area in the lateral angle of the eye, and external nasal branch of the ethmoidal nerve, which is passing through the ethmoidal groove of the nasal bone, if you remember. It's responsible for innervation of the anterior part of the nose. So the dorsum nose and apex of the nose is innervated by this external nasal nerve branch of the ethmoidal nerve, anterior ethmoidal nerve, which is branch of the ophthalmic nerve. And again, very nice picture that is showing you the territory of the V1. So all this part is the sensitive innervation is made by the V1. Maxillary nerve, it gives several branches that is innervating the sensitive innervation of this part of the face, as you see, mainly the area of the upper jaw. That it passes through the foramen rotundum and it goes to the pterygopalatine fossa, we said it. It gives here in the zygomatic region the zygomatico-temporal branches, which is going to the innervation of the sensitive innervation of the small part of the temporal region. And also it gives the zygomatico-fascial branch, which is responsible for innervation of the cheek region, the skin of the cheek region. And a very important nerve is a branch of the maxillary nerve, which is called infraorbital nerve. And this infraorbital nerve that is passing through the infraorbital foramen, but before it comes to the infraorbital foramen, it passing through which opening of the skull to the orbit? Inferior orbital fissure, very important. Inferior orbital fissure is going from the inferior orbital fissure to the infraorbital sulcus, infraorbital canal, and is coming out as an infraorbital foramen. And immediately it gives 4 branches, extremely important. One branch for the lower eyelid. One branch is called levator inferior palpebral branch. One branch to the superior lip. So the innervation of the skin of the superior lip is by infraorbital. One branch as a nasal branch, the lateral nasal or external nasal branch for the wing of the nose. And one is internal nasal branch for the nostril or the opening of the nose here. So these branches, these 4 branches, they are making pes anserinus minor. You have heard about the pes anserinus major. You know where it was? It was in the insertion of the 3 muscles in the lower limb, and they are sartorius, gracilis, and semitendinosus. Yes, just to refresh your knowledge. So this is another pes anserinus, but is a minor, and those are the branches of the infraorbital nerve that is innervating this part of the face. And again, very nice picture about the territory of the cranial nerve number V2, the 5, the second branch, the maxillary nerve. So all this area is responsible for the sensitive innervation of area of the or territory of the trigeminal. And finally, mandibular nerve, that is a little bit different from the other branches of the trigeminal nerve, because it not only has a sensitive branch for the innervation of this large area, but also it has a motoric function or for the innervation of the masticatory muscle and some other muscles that we mentioned it, like anterior belly of digastric muscle and mylohyoid muscle, which are the muscles of the suprahyoid muscle. Be careful. You will have an e-lecture, yes, you have an e-lecture from the suprahyoid and infrahyoid. Be careful of the different type of the innervation of these muscles, yes. So it has an auriculotemporal nerve, is innervating a huge area of the temporal region and also the external acoustic meatus and tympanic membrane. Then it has a buccal branch. Remember, I said it before, this is a mistake of a lot of students. I mentioned it, I remember in the lecture, but once more I say and emphasize for that. Buccal nerve, which is branch of mandibular nerve, is pure sensitive nerve. it means is responsible just for the sensitive innervation of the skin of the buccal region and the mucous membrane of the buccal region, yes? But if you remember that we said that if you put your hand in the face region and you will have the 5 branch of the fascial nerve, one of them it was buccal branch of the fascial nerve, that is motoric branch, which is responsible for innervation of the buccinator muscle, yes? So different between the buccal nerve branch of the mandibular nerve, which is pure sensitive for the sensitive touch, temperature, pressure of the buccal region and inside and outside, and buccal branch of fascial nerve from the parotid plexus, which is pure motor for innervation of mimic muscle. One of them is buccinator muscle, yes? Don't do mistake. And as you know that here we have a mental foramen, and through the mental foramen is coming out the end branch of the structure that they pass through the mandibular foramen and mandibular canal, which is the inferior alveolar nerve artery vein. So they are passing through the all foramen and all the mandibular canal, and finally it end up the canal as a mental foramen, and here is coming as a mental nerve artery and vein through the mental foramen. So this is the end branch of the inferior alveolar nerve, which is branch of mandibular nerve. Again, don't do mistake, through the foramen, mandibular foramen doesn't pass mandibular nerve. It passes inferior alveolar nerve, which is a branch of mandibular nerve. This is another common mistake of the student. And finally, this is the green area, is the area for the territory of the sensitive innervation of the mandibular nerve. And we said that the difference with the other is that the mandibular nerve, it contains the motoric function as well. And this is more or less the same things that we said it with the name of the nerves that we mentioned it here. Motor innervation that already we discussed, we said that is mainly is innervated by the trigeminal nerve and the branch, it's mandibular nerve, and fascial nerve that already I said that is responsible for the innervation of mimic muscle, the muscles of the epicranius, it means fronto-occipital belly. The occipital belly is via the posterior auricular nerve, not only innervating the posterior auricular muscle, but also the posterior belly of the epicranius muscle. Is coming from the parotid plexus. We already mentioned 5 branches. Remember these 5 branches that is coming from the parotid gland. This is, for example, is important that if somebody has is going to be operated via inside the parotid gland, for example, the parotid gland tumor. So the surgeon must be extremely be careful not to damage the fascial nerve. Yes, sometimes it's not possible. Sometimes this is this malignant tumor of the parotid gland is going to the deep structure and is expanding. So you will inform the patient before operation that he most probably lose the innervation of the mimic muscle, because the patient really must have sign, because if he doesn't sign, he has to know, because you will say you have to choose, either you will be alive or you will not be alive, or you will soon die if we don't operate it here. So, but the risk is of the surgery is that you lose the innervation of the mimic muscle. Nowadays, we have a modern technique that we are suturing via the neurosurgery, via the microscopically ending of this nerve together. So, but still they are paralyzed of this nerve. Yes. So the patient must know and has right to know that after the operation he can not control the mimic muscle, and this is crucial, because if he doesn't agree with you, he will not appreciate you that you save his life, but he will sue you that why he cannot, the angle of the mouth is coming down, or why he cannot close the eyes. Yes, it cannot control the mimic muscle. So that's why remember, and you see that how this fascial nerve, and they are very thin nerves, and very easily it will be prone to damage, yes. So these branches, remember. And very important, again and again, the cervical branch of the fascial nerve is responsible for innervation of platysma, the muscles in the neck, the superficial muscle in the neck. And here is the posterior auricular, which is innervating the occipital berry of the occipitofrontalis muscle. We mentioned it, and the posterior auricular muscle here. Except the cranial nerve, we have the another nerves that they are responsible for innervation of especially neck region, and those are not cranial nerve, those are called spinal nerve. And a spinal nerve, you have a huge chapter in the second semester. The spinal nerve that they are coming and arising from the part of the cervical segment of the spinal nerve, especially C1 till C4, the ventral branch of these nerves, they are fusing together and they make the plexus, which is called cervical plexus. I don't want to go to the detail. And just to know that the cervical plexus is formed by the ventral branch of the spinal nerve of the segment of C1, C4, that they make the plexus. And from this plexus is arising some nerves that they are responsible for innervation, the sensitive innervation of this area, the neck region and some part of the head region. And also, as I mentioned, some part of these branches, they are making the ansa cervicalis, the deep ansa cervicalis, which is responsible for innervation of the most of the muscles of the infrahyoid muscle that they call it strap muscles. Yes? That you have in the lecture. So this is the region that the sensitive branch of the cervical plexus is coming out, and to understand this this point, which is called Erb's point, remember this. This is called Erb's point or punctum nervosum, or nerve point also is called, where you can find what is this muscle, which is covered by the investing layer of the fascia, sternocleidomastoid, which is easily palpable here and is a large muscle. If you get the origin of the sternocleidomastoid, which is coming from the sternum and the medial part of the clavicle, is inserted to the mastoid process and superior nuchal line in the posterior margin in midway, so in the middle. Here is the place of Erb's point. Here is the place that 5 or some nerves is arising and is perforating the investing fascia of the neck and is responsible for innervation of the head and neck, the sensitive innervation. They are lesser occipital, is occipital region, is greater auricular, is innervating the some part of the occipital and parietal, some part of the temporal, and of course the parotidomastheteric region and the ear. Then there is a transverse cervical, which has very important communication, be careful here, with the cervical branch of the fascial nerve that it was responsible for innervation of platysma. This cervical branch of the fascial nerve that is coming out from the parotid gland is anastomosing with the transverse cervical or transverse chole nerve is arising from the cervical plexus. So it has a sensitive branch and motoric branch from here. And finally, we have the supraclavicular nerves that they are going above the clavicle and is supplying the region of the clavicle and some part of the thorax cavity. And here, after the dissection of the investing muscle, investing fascia and the sternocleidomastoid, sorry, you can see the punctum nervosum or the Erb's point and those nerves that we mentioned it. And here is very nice with the segment that you needed for the second semester. So those are the area. And the last part of the innervation of the head region and neck region, those are the dorsal branch. This cervical plexus, they were ventral branch of the C1, C4, and from there it's arising the sensitive nerve from the punctum nervosum and some motoric fiber as a deep ansa cervicalis. But the dorsal branch of the spinal nerve, they are responsible for the sensitive and motoric innervation of the muscles of the back. So the nerve that is very famous is the suboccipital nerve, the greater occipital nerve, and the third occipital nerve. The greater occipital nerve and third occipital nerve, this one and this one, they are responsible for the sensitive innervation of the backside of the occipital region and the backside of the neck. And one nerve, which is here, which is called suboccipital nerve, it's the dorsal branch of the spinal nerve C1, is a motoric function and is innervating those muscles that previously I said, this obliquus superior and obliquus capitis inferior and rectus capitis posterior minor and major. So suboccipital nerve. And this is some again point for the cervical spinal nerve. There are 8 cervical nerves, C1, C8. This is the information that is very important skeletotopically. How the nerve is coming out is responsible is for the second semester. Then the cervical plexus is arising from spinal nerve C1, C4, which is the ventral branches. One of the nerve is important that it's going to the thorax and responsible for innervation of the diaphragm. Phrenic nerve is coming also from the cervical plexus and is responsible for innervation of the skin of the inferior part of the head. The other C5, C8 is making another plexus, which is brachial plexus. That is responsible for innervation of the muscle and sensitive innervation of the upper limb. If you remember, ulnar nerve, musculocutaneous nerve, radial nerve, median nerve, they are arising all from the brachial plexus that you will discuss in the detail. We will discuss it in the second semester. And the last chapter, and very quickly, something about the lymphatic drainage of the head and neck. Just to ask you, why is important the lymphatic drainage? Is anybody knows? Why we have to have some lymph nodes in all over the body? Yes. The dead cells can be, yes, but not only dead cells, but also or bacterial infection, or the viral infection, or cancer cells, yes. So that's why it's the topic of interest of every physician, the lymphatic lymph nodes or the lymphatic drainage, because you have to know that if remember the basic things. 3 reasons you have the lymph node in all over the body, yes? And there are 3 reasons that this lymph node, usually this lymph node, they are not palpable, yes? If you touch any part of your body, if you are a healthy person, it's not palpable, yes, generally. The largest one, for example, some is here in the inguinal region, yes, near to the inguinal region. 3 reasons is increasing the size of the lymph node. First, inflammation or infection, because they are catching this microbe and they are enlarging. Cancer, metastatic cells or cancer cells. And some primary disease of the lymph nodes, like lymphoma or some parasites, toxoplasma, malaria, AIDS, Yes, they are enlarging the lymph node. Yes, those are the regions. So that's why you have to know that if somebody coming to you and say that I have something here, for example, in submandibular region, so, and is enlarged, and you have to touch it, you see that how much is big, if it is movable or not, if it is hard or if it is soft. All this is very important information for you. Yes, or if it is fixed somewhere, is like a stone, you touch it. Those are all is giving some information and some idea to diagnose this disease. And then when the patient will come to me, for example, with this submandibular lymph node enlargement, I have to know which area of the head region is draining to this lymph node, to know and look for some potential reason for this enlargement. Either the infection is in this area or cancer is this area. So I will do another examination like a CT scan or MRI or sonography and the other blood test to see why the lymph node is enlarged. Mostly it's infection. It can be tooth infection. And if I treat the tooth infection, this lymph node is disappear, the enlargement. Yes? So that's why to know why we have lymph. And this lymph node in the head and neck region, we have some groups of the lymph node. We have occipital lymph node. We have retroauricular lymph node. Be careful here, some books you can find it, the mastoid lymph node, for example. We have parotid lymph node. Parotid lymph node, they are divided to the superficial and deep. And you have here the submandibular lymph node here, in submental lymph node here, and very important lymph node, group of lymph node that they are going parallel with the jugular veins. We have 3 jugular veins, external jugular veins. You have it in the video, in the recording lecture. And in external and anterior jugular vein, they are superficial vein. So that's why those lymph nodes that they are parallel with those veins, they are calling superficial cervical lymph node. Yes. Internal jugular vein, which is very important, and always parallel to the wall of the internal jugular vein, you have a series of the lymph node, which is called lateral deep cervical lymph node, because it's located in the lateral part of the neck. And generally, it's called the lymph node, the jugular lymph nodes. Yes? So this is the first classification that you have to know. I said the submental and submandibular, so here is the schema of how it is. This is the anterior belly of the digastric muscle, is the suprahyoid muscle, and here is the body of hyoid bone, and here is the chin region of the mandible. So this part is the submental trigon or triangle. And in this submental triangle, you can see a few lymph nodes exactly here in the midline under the chin. And those are called submental lymph node. And if you have a knowledge that this lymph node, they are receiving the lymphatic drainage from tip of the tongue, from central part of the lower lip, from the incisor teeth and gingiva, and that's it. So if somebody come to me and it has an enlargement of submental lymph node, I don't go look at the occipital region or parietal. I go directly to look at the tip of the tongue, look at the lower lip, look at the teeth. And I have to find some reason for the enlargement of this lymph node. Yes? Yes? So suddenly you will see that he has a cancer in the tongue, for example. Yes. So, and this is the reason. And another lymph node, very important lymph node in the neck region, is submandibular lymph node. Those are the submandibular lymph node. And as we said, the submandibular trigon is bordered by the anterior belly, posterior belly, and the inferior margin of the mandible. This triangle is called submandibular triangle, and in this place you have the submandibular lymph node. So, 2 classification of the lymph node. We have it in the head and neck region. Some of them is making a ring around the head region. So they are the ring group of this lymph node. They are occipital, mastoid, retroauricular, the parotid lymph node, superficial, deep, and submandibular and mental. And here there is a central part of the lymph in the beginning of the jugular is the connection of the fascial vein to the internal jugular vein. It's this ring part. Another group of the lymph node, as I mentioned, is they are parallel with the passage of the internal jugular vein. Extremely important, and they are called string lymph nodes. They are vertically, they are going as the chain is going parallel on the different part of the internal jugular vein as a lateral deep cervical lymph node. Yes? Be careful of to name specific lymph nodes, especially. One group of the lymph node is the place that the digastric, posterior belly of digastric muscle is crossing the internal jugular vein. This is called jugulo-digastric lymph node. Jugulo, internal jugular vein, digastric lymph node. This is one group of the lateral deep cervical lymph node. The other group is the group that is crossing the omohyoid muscle with the internal jugular vein. This is called omojugular or jugulo-omohyoid lymph nodes. Those are the Kittner, and here is the Kocher lymph nodes. They are very, very important for the lymphatic drainage of the tongue. For the carcinoma of the tongue or cancer of the tongue, those two, they are very important, yes. So, and here, what I said, that those are the area, and you have this picture from the tongue lecture of me, that the tip of the tongue, apex, is going to the submental usually. The margin of the tongue, which is the most common site of the cancer, especially for the people that they are alcoholic or they use some tobacco or a smoker. So they are going to the submandibular. The base of the lymph nodes, the base of the tongue or the backside of the tongue or root of the tongue is draining to the deep cervical lymph node parallel with the internal jugular vein, which a place that is crossed by the posterior belly of digastric is the jugulo-digastric lymph node here. Yes, and the backside of the tip, it means here in this region, it can go directly either to submental or go directly to the jugulo-omohyoid lymph node here in this part. So, and another important of the tongue, the lymphatic drainage of the tongue is extremely important, and you have to know that this lymphatic drainage, it can cross with each other. Yes? So, it can go, the lymphatic drainage from the right side, it can go to the same side, but it can go to the opposite side. Yes? That's why we are not surprised that if the patient will come to me and then I will find the cancer in the right side of the tongue, but he has enlargement of the lymph node in submandibular region in the left side. And this is the explanation, that these lymph nodes, they are crossing each other, yes? So that's why the palpation of these lymph nodes is important, and this is a classification that definitely you have to know it. The general medicine, they have to have idea, and the internal and the dentistry, 100% they have to know this classification. You will be asked in the state exam that how, for the staging of this tumor, sometimes we need to operate. We need to remove these metastatic lymph nodes that they are in the neck. They are called dissection of the neck, and in this direct dissection, we need to know till where we can remove these lymph nodes. Yes? So area of submental and submandibular is number 1. The superior jugular area is 2. Middle jugular area 3. Inferior jugular area is 4. The posterior triangle of the neck, the region that accessory nerve is passing here is 5, and anterior region of the cervical region is number 6. So the pathologist, under the microscope or due to the magnetic resonance or CT scan, the radiologist can write that this area is affected, yes? And then you open and you send it to the pathology and they confirm that it has a metastatic cells or not. So the surgeon start to remove here, here, here. And if the pathologist say, here, I don't see any metastatic cells, so we stop. We don't go further, yes? It means that it didn't reach down. So that's why it's important this spread of these metastatic cells, or it can be infection to the other side, and they are the central part and the peripheral part of this lymph node. And usually the experience is showing that if there is a central involvement, it means the junction of the vein together, so there are the serious disease. But if there are the peripheral lymph nodes that are involved, so usually it's the localized some tumor or infection. And here is, for example, the superficial this is the external jugular vein, which is a superficial vein of the neck. And whenever you find the lymph node parallel with the vein, so this is called superficial cervical lymph node. If it is parallel with the internal jugular vein, it's called, because it's a deep vein, it's called deep cervical lymph node. And both of them, since they are located in the lateral part of the neck, they call it superficial lateral or deep lateral cervical lymph node. So just to know this classification, and of course the bimanual examination of those lymph nodes is extremely important. Usually we are standing behind of the patient, and from the backside bimanually you compare left and right. You compare left and right, and you start from the anterior one, and slowly you go down to the supraclavicular region and so on. For example, just one last information, the supraclavicular region cannot be only in the head and neck region. It's one of the sites of the spread of the metastatic cells of the breast cancer. So the first sign that the lady will come and you find the enlargement of the supraclavicular lymph node, for example, yes, or lung, yes. So those are the things, and the last clinically things that it's extremely helpful for your general knowledge is usually the lymph nodes less than 1 centimeter, the size is normal. If it is becoming more than 1 centimeter, it's dangerous. Usually if you touch and the patient has a pain for that and is very sensitive, is a sign of the inflammation, yes? So good news, somehow good news. If the consistency is soft, you touch it, it's rubbery, it's lymphoma, it's a direct tumor of the lymph nodes. If it's hard, it's fixed, it doesn't move, and it's very hard, it's a sign of cancer. But of course, you cannot 100% say, since you don't take a biopsy, you take it to the pathology, and pathology will write it, written, that this is carcinoma of this thing, you never say the patient that is. You can say, I think, or is suspecting something serious to prepare the patient, but 100% information of the diagnosis after you have a paper of the biopsy. Yes, you can say. Thank you for your attention. Selfie. Yes.
Do you know where
You
we
want to
can
make a
find?
selfie?
I forgot my phone. Do you know where we can find the information about the accreditation MUDr?
Yeah. Where actual information.
Okay.
The first one. If you have it in the mobile, you have it in sure. Actual information. Always look at a student. Always look at the actual information for the student. Yes. All the information that we are telling you in the lecture and this thing is written in the MUDr. Yes. Get to used to it so often. In the MUDr, the first line is actual information or something like this is written for the student of first year, and is written about the exam. Go to anatomy. Anatomy. No, anatomy. Where is the model?
Like it's called lectures actually.
No, lecture is different. You go to the website. No, here. Basic information first. If you go.
But that's informatics.
No, basic information of the actual information. There is something here. I see as a teacher something else, yes? That's why the anatomy, yes, exactly. And here, actual information, current information. Here.
Yeah, perfect.
So here is written that Professor Ferda will determine. I mentioned you that the lecture will do. After that, the test in anatomy, here is Czech, and here is English. Yes?
Okay.
So all information is here. Always look at here, yes? Everything that you are saying is here.
Okay.
Yeah?
Thank you so
Yeah,
much.
bye-bye. Hello.
For the next test, I have books, but I don't know which to study from.
Lecture.
From the lecture,
Lecture and practical. The best one.
oh, not the books.
You can see the book also, but what we say, it's the from book also, but we select the most important thing and we give you there. Yes? Because book, it's 3,000 pages if you have a Gray's Anatomy, and maybe some of them is not that much important for you, is a reference book. So the best one is what information that you have in practical and lecture. So it's 99% is sufficient.
Okay.
Yep.